Is now. This is it. We gotta get locked and loaded, ready and rocking. So, spinal cord injury. Yeehaw. We yapped for about 2.5 hours yesterday about the head traumatic brain injury. Now we're gonna talk about a spinal cord injury. Yay! So, essentially, this is what we're looking at here. That's what we're looking at here. And each of these different vertebrae is protecting a different part of the nervous system. They've separated the spinal cord into, basically 4 sections with a little tail at the end. I think that's actually what it's called, horse's tail or something. But we have the cervical part of the spine, which is, it's got 8 pieces. Yep. 8 pieces of the cervical spine, starting with C1 all the way down to C8. Then we go into our thoracic spine that starts kind of below the clavicle, goes down. It's got 12 pieces all the way down to kind of like right above the perineal area. So we have cervical, which is 8 pieces, thoracic, which is 12 pieces, lumbar, which is 5 pairs, right? All the way down kind of to the ankle part, and then the sacral area, which is, you'll see here, is more of that posterior area as well as the peritoneal area. No, perineal. Bleh, adding a T where it doesn't belong. Perineal area. Which is all to say that a spinal injury is not good. The way that the spine works is, let's say you've got a break like right here, like right there at like T4, okay? So if you get a breakage there or any sort of issue with your spinal cord there, okay, everything below that area will cease to function. It's almost like cutting a rope, right? You can't climb on the rope part that you just cut off. It's not working. It's literally fallen to the ground. So now all you have is the things above where the break was. So at T4, right here, you will not have access to any of the stuff below that. Any T5 all the way down to S5, okay? That is just the sad situation of when it comes to a spinal cord injury, okay? They have some classifications here, which include complete and incomplete, where if it's complete, it's 100% cut off. Like you can't get the function of that back. It is gone. Everything below that is gone, and now we're looking at rehabilitation. And then incomplete is like, maybe you might have some partial use. That's where maybe there's just something pressing on it, or it might not be 100% wrecked. So the question there is just, as far as rehabilitation goes and reintegrating into the world, what it looks like maybe to regain some function. If you've got a complete spinal cord injury, that's just, you can't really get that back. We have not found a way yet to grow back nerves in that context, in the spinal cord. So it's kind of like, well, do your best. But with an incomplete spinal cord injury, there's a chance that maybe there's still some use that can be recovered simply because it hasn't just been completely severed. We talked about level of injury. Remember, everything below the level of injury, so that and below, you don't have access to. Or don't have access to in the way that you used to. So if you've got a T9 problem, let's say it's a complete issue. Everything below that, your legs, your hips, your bowels, you don't have nervous access to that. So a lot of the skeletal muscles, those ones that have you being able to control them, right? Your voluntary movement is taken away. You may have involuntary movement, so it's like not like you will not be able to poop or anything. It's just that your external sphincter that you would normally control are not, no longer control that. So there might be some incontinence there, just something to think about. Yeah, level of injury, that's important. Now, I talked a little bit about this level of injury thing with C1 to C4, C5 to C8. Anything above C5, and the reason this is important here, anything above C5, which is this part that's kind of here underneath your shoulders, you may have a risk for losing your ability to breathe, which is kind of a big deal. That's our airway and our breathing. If we lose the voluntary aspect of our breathing, if we're looking at the chance that there's a spinal cord injury, because that's like C3, C2, like we're looking right there. That's our spinal cord or our brain stem, right? If we're looking at that kind of brain stem problem where our medulla is, which has to do with all of our autonomic functions, that's going to be a big issue, all right? So we want to be making sure that if we are looking at a C4 to C1 spinal cord injury, we are constantly going to be wanting to assess that this person can breathe. That is, and like that's the first thing that's going to kill a man. Like, it would be a bummer now that you can't use anything below that, but you're going to die a lot faster if you can't breathe. From C5 to C8, those are going to be our arms, shoulders, arms, fingers, kind of a thing. From C5, that's going to be more of our biceps, triceps. C6 is our forearm, and the C7 and C8 are our fingers. So if you're able to use your fingers, you can tell that at least that spinal cord injury has gone below C8, okay? C8 and C7 are our fingers. C6 is up, is the aspect of the thumb. But yeah. And then our thoracic area is mostly our trunk. But you can see here that the T2 and T3 are, I misspoke earlier, are mostly our triceps and the posterior aspects of our arm-ish, medial aspects of our arm in this picture. So, sorry, I just swallowed right into the microphone. Lumbar, beneath the trunk and sort of the waist area and the front part of the legs, and our sacral area is the posterior aspect of the legs, and a bit of the pinky toe, which, listen, if you've ever tried to move your pinky toe on its own, it doesn't really work that well. But that's probably an aspect of balance, and, of course, our genital area. So yeah, remember, C has 8 parts, T has 12 parts, and lumbar and sacral both have 5 parts. All right. Risk factors. So the risk factors here in the association of a spinal cord injury are most to do with accidents, okay? The spine is something your body really desperately wants to keep intact. So in general, like, you'll see here, one of them is kind of a prognosis issue where it's like you've got a disease process here. Most of the time when these events happen, it is due to an accident, a fracture of the spine that leaves lasting cord damage. Now, they have here ages 16 to 30. Those are going to be your risk-taking ages. When you're most likely, your frontal lobe is maybe not as developed as it probably should be. You're maybe doing some pretty stupid things because you think you can. Especially at that age, people have this idea that you're invincible. And unfortunately, we all have to learn that the hard way in some form or another. Being male, more likely to take risks, especially at younger ages. High impact sports like football, diving, anything that could put compression on that spine, anything that could knock something out of alignment, anything that could cause a just back to crack. And you'll notice here in some of the, so hyperflexion, which is the head thrust forward, that can happen with any sort of like pushing injury if you're, kind of whiplashed a lot. Diving, right? We were talking about axial loading, blow to the top of the head. If you've got the wrong form in diving, it's been known to totally just cause a spinal cord injury right up at the top of the C's. So that is, that could lead to death or becoming a quadriplegic. So not, you got to be considerate of these sports. They're not just, they are recreational, but you got to be careful and cognizant of the risks involved. Alcohol or drug use, and remember, that's not due to the alcohol or drug use. It's because those activities can cause you to do stupid things or take on risks that maybe you wouldn't have if you weren't on drugs or alcohol at that time. So, drug and alcohol abuse more likely to cause somebody to perform an activity that would result in a spinal cord injury. Metastatic cancer, that's more of a tricky one because that is a disease process leading to a growth in the actual, of cancer in the actual spine, which could cause a mass to be formed, could cause, destruction of tissues there, and yeah, not great. And then, of course, falls, especially in the elderly. Now, this is where it differentiates. We saw these are all they all seem to be kind of related. And falls is a bit of a different one. That's what puts the older population at risk for having that kind of issue. I mean, especially when you're older, your bones, your ligaments, your joints, they're all a little bit less proficient at holding you in one place or keeping you stable, as well as, making sure that if you do fall, things don't go horribly wrong. And if you do fall, there's always a chance if you are older or you've got, especially if you have something like osteoporosis, that you get a spinal cord injury. Here's more causes. Just in general, we talked about hyperflexion, where your head is thrust forward. You'll see there that puts a bunch of pressure and can cause a crack in the actual vertebrae of the spine, which compresses and may even break the spinal cord. So that happens in a high impact thrusting injury where it is just extra acceleration and force pushing you forward causes your head to take a brunt of that damage, and you right there. Hyperextension is going to be the exact opposite, where your head is thrown backwards. And in a coup-de-coup or coup-counter-coup injury, right, you're looking at having your head be thrust forward, and then when you hit something, right, that counter force shoves your head backwards, causing perhaps hyperextension. Now, especially if you don't have your headrest at the appropriate place, your head can be thrust backwards, causing the exact opposite problem to happen here, where the spine of the spinal cord, it's called something really fancy. Let me even see if I can find it. Anyway, it crashes back, and now you've got the opposite problem. Both of these, hyperextension, hyperflexion, can cause a spinal cord injury. And you'll see they have a car accident here because those are classic ways of having both hyperflexion and hyperextension, depending on where they hit them, right? If it's a back, getting rear-ended, hyperflexion because you're carrying all that extra momentum from the car in front of you or behind you, and then can of course cause you to shoot your head back as a coup-counter-coup injury. More causes, we talked about axial loading when it comes to diving, when you're crushing the vertebrae from the top down, right? If your head is going straight down into the water, all of that pressure that's exerted from the water is now going onto the top of your head, which can cause a crushing fracture that crushes your vertebrae together, causing that spinal compression and injury. And then we have vertical compression, which is where you land on your feet or your buttocks, which is the exact same concept of axial loading. The only reason this is called axial loading is because the top of your, I want to check this, but I think the axis is the top of your, it's the second. Yeah, it's your second, it's your C2, I think, actually. Axis is C2, yep. And so it's called axial loading because this top of the head injury puts pressure on the axis being C2. Vertical compression, we see this lady, feet first. Any sort of landing movement she's going to have is going to put pressure on her sacral, her coccyx, her sacral area of her spine, which can, of course, cause compression in the opposite direction. It just so happens that axial loading is going to start up higher. Vertical compression is usually going to start up lower. So in general, axial loading is going to get you more likely to have, problems below that area, a lot more problems than vertical compression, where it will very likely end when that compression does, right? Axial loading is pretty high up. There's not much more, or there's a lot more underneath that. More causes a penetrating injury, such as like a gunshot. A gunshot can very easily, if a gunshot can blast through the skull, it can very easily sever your vertebrae in your spine, causing a spinal cord injury. So low speed has an impact at the local site, which is a really fancy way, I guess, of like saying that if something hits you slower, there's less of a chance it's going to spread out to other areas than just where it hit. If you're looking at a high-speed injury, a high-speed penetrating injury like a gunshot, so low speed, if you're just like stabbed in the neck, it's going to cause more just damage to that specific area, because it's not like I'm going to be stabbing you at the speed of sound, right? It's going to be penetrating where I initially went. With a gunshot, however, that bullet is going very, very fast. It may go all the way through. It might not have even shot your neck. It might have shot really close, right? But it's simply the fact that it hit you so, it hit you at such a high speed that it's more likely to cause damage. So if this is your spine and you were shot here, it may cause damage to your spine just by being close to it and just putting pressure on that site. Direct and indirect damage. It's the idea of if you hit something harder, there's more damage that's spread out, right? And here, right, speed doesn't necessarily equate to the strength of a punch, right? But any sort of, if you are going to cause damage and something is going to come faster at you than slower, that faster deal is maybe going to cause more impact, not only to the site, but maybe even indirectly. So here's the difference between a complete and partial spinal cord injury. You can see here, that is very, very likely a complete issue. It's a dislocation of the spine where maybe there's a chance that the spinal cord is stuck right there, but it's less likely because of, look at how much space there is right there. Look at how much space there is where the spine used to be. That's really not good. That is a fracture with a dislocation, which leaves not a whole lot of space. Now, let's say the spine did survive, their spinal cord did survive, and it's stuck in that one area. It's going to be incredibly compressed. That person is going to be having extreme numbness and tingling, pain, like neurogenic pain. Not great. Now here, we can see that there's been a compression fracture. The actual bone has pressed into the spine, causing damage and causing it to be incredibly compressed. This is a bit less of an extreme dislocation, but you can tell that it is offset, putting pressure at this site. So, priorities. Well, when it comes to priorities, of course, okay, of course you want to make sure they're breathing. But when it comes down to how do we treat the spine, we do not want the spine to move. We want to not let the spine move because that can cause more damage, especially if it's higher up. If somebody's head is flopping back and forth and you know that they're at a risk for having hit their head and have that spine injury, you don't want their head to be flopping back and forth because those vertebrae are meant to move with the head movement, obviously, right? The skeleton has to move as your muscles want it to move in a sense, right? However, if you're not keeping that immobilized, you could be causing further compression, further damage to the spinal cord, which sits in here. Sits in the little circle there for the spinal cord, causing it, if the spine is just moving back and forth and back and forth, I mean, you can get bits of compression in your spine just by having bad posture, by, having really tight muscles. Think about when you've actually had a traumatic injury to that spinal cord and then, by not immobilizing something, you're causing further damage. So in the acute phase of a spinal cord injury, you have to make sure that their head does not move. You want to keep that stable. That's why, when EMS comes into the site of where there's a chance that there could be a spine injury, any sort of car accident that has left the person, kind of flopped out, most things, if it has to do with the head, they are going to instantly, put you in a collar of some sort or keep your head incredibly stable because they don't want your head or you don't want that spinal cord injury, if it's happened, to get worse. Now, we have two terms here that look like they should be the same thing, but they are absolutely not the same thing, and they're totally different. So, spinal shock. Now, we talked about shock at the beginning of this semester, and shock is shock is a system-wide circulatory problem that has to do with the fact that your blood is not able to get to the vital organs and perfuse them, causing ischemia of the vital organs, and if not treated with fluids and blood products and vasopressors and fixing the problem, that person will die because their vital organs are now not able to sustain themselves, okay? Spinal shock is not that. Why is it called spinal shock? I don't know. It was kind of a quirky name. They were like, wow, that's so cute and fun. Look how fun and fancy it sounds. Spinal shock happens in the most acute phases of having a spinal cord injury, okay? So if you have had that spinal cord injury, or even just a substantial amount of pressure or damage to an area, it might not have even caused it might not have caused damage that is unfixable. Like, you may be able to rehabilitate yourself after that. But in a case of spinal shock, you've lost, and it's a temporary, they say here, temporary loss of sensation and motor function below that place. And it might even, in that case of spinal shock, because it is such a quote-unquote shock to your body, right, your symptoms may be presenting at a higher part of your spine than you actually got the injury, simply due to the inflammation of the area where your body's like, whoa, send everybody, we gotta fix this, problem. I'm messing with my stuff because, I want to make sure that my audio is not freaking out all the time. I don't know. Maybe that works. I don't really know. That's a lot better. Maybe it's better. I don't know. I don't freaking know. Hopefully I didn't screw this up forever, but I'm getting output, so that's pretty good. Anyways, yeah. Anyways, so spinal shock. it is and it shows as spinal shock because below that area of injury, which I even mentioned may be a little bit of a, it might be not, the symptoms might be showing above the area of where the injury actually took place simply because inflammation, but underneath that area, you're going to see flaccidity. Okay, that person is going to have like noodle limbs, like floppy. They're not going to be able to move them. Okay, that's where spinal shock comes into place. And this happens in the very acute phases after a spinal cord injury, right? Like right after it's happened, a day after it's happened, whatever. Okay, you know that spinal shock is progressing and moving forward from not being spinal shock anymore, being finished with spinal shock, because it is something that happens when your body freaks out, because it's like, whoa, stop everything. We need to make sure that it's a freak out from your body, essentially. You lose that function. You realize you're going out of spinal shock when that flaccidity turns to stiffness. So you go from having noodle limbs to having limbs that are very stiff, very they're hard to move for the person, but also, they don't want to move. They don't want to move. The limbs are stiff, and that's how you know that the initial acute area phase of spinal shock is finished, right? Because now those limbs are stiff. But that is the concept of spinal shock. It's not like life-threatening in the way we would think of shock as life-threatening. Now, of course, there's a safety issue here. We want to make sure that this person is, not going to be injured while in this state. But at the same time, you're not in a complete circulatory collapse, right? It is simply your spine is freaking out, your body is freaking out, and so you're going to see that flaccidity in the limbs underneath, or any sort of area underneath the injury. And then after it's over, those areas will become stiff again, and even too stiff. Now we're talking about neurogenic shock. So neurogenic shock is actually the real thing. Yeah, neurogenic shock is actually that idea of systemic, that's the word I was looking for, systemic circular collapse. And this has to do with vasodilation. Okay, now in order to understand why this is caused by vasodilation, you have to understand the vascular system as a whole, okay? Your veins and your arteries, all your vascular system, they're like normal state, okay? If you were to turn off the body for a minute and have everything go back to your, like, it's like looking at anatomical position. Nobody stands like that. But in the way that we classify the body, right, that is the body's way of being, okay? Everything is in line. If you were to turn off the body's regulatory processes, the vein or the jugular system would always be in a state of vasodilation. Okay, that is the way that they kind of would love to function. They want to vasodilate. It's almost as if having your muscles, when they're not, like, your muscles don't start in a flexed position. Okay, now they may not be extended either, but they are, like, they're not working. Your muscles aren't going to be flexed. When you're not using them, they're not flexed, which is similar with your blood vessels. Instead of, however, in your muscles where it's one action of pushing or pulling, now you've got an issue where it's actually like the vessel itself is circular, okay? In a relaxed form, that circle kind of becomes bigger, right? When you hold your hands in a, like, circle, that's the way that it is. And we'll consider that vasodilation, okay? Your vessels can get that big, and they could rest that big if they wanted to, all right? The issue, of course, comes when you are looking at vasoconstriction. Vasoconstriction, now you're moving, if you make that hole in your hand smaller, right? Keep your thumb in one place. You still have that ability to vasodilate, of course, if you move your hand back, but now we are looking at the actual muscular movement of your vascular system. I think, and I'll double check this, I think your vascular system are your blood vessels smooth muscle? Yes, they are. Of course they are. Duh. And smooth muscle is always autonomic. Smooth muscle, you do not have the ability to look at your blood vessels and say vasoconstrict in the same way I'm able to move my arm and flex or, walk, okay? Those are all skeletal muscle, which I do have voluntary control of. I don't have voluntary control of my smooth muscle, okay? And my blood vessels are made of smooth muscle. My blood vessels are made of smooth muscle. My digestive tract is made of smooth muscle. Also, some skin. Interesting. There's also cardiac muscle, which we also don't have voluntary control of, but that's kind of a different thing. It's different. It's more special. Okay? Look at all that smooth muscle stuff. Oh, okay. Cardiovascular system. We've got smooth muscle because that's, remember, our vascular thing. That's vascular, part of the cardiovascular system. Gastrointestinal tract, genital system, integumentary system, respiratory system. Already we're looking at airway, breathing, and circulation problems. I wonder what could go wrong here. Okay. Our renal system and also some sensory stuff. So. In neurogenic shock, if our body has lost the ability to regulate our vascular system, we can no longer vasoconstrict to increase, because remember, right, vasodilating is great when you've got a lot of blood, okay? In the case that you don't have a lot of blood, your body needs to be able to vasoconstrict, right? Because when you vasoconstrict, your blood can keep moving, because remember, your blood vessels are a pressure system. If there's not enough pressure in your vascular system, the blood is not going to move. It's not going to move. And if the blood's not moving, it's clotting, right? Or it's not going to move quickly enough to make it to your organs in time to perfuse them before they're starting to be like, hey guys, we just became anaerobic. Now, vasoconstriction is great. Now, too much vasoconstriction is bad, and we'll talk about that later. But, okay, in the problem of neurogenic shock, the person who has this, right, they've had this spinal cord injury, they are unable to vasoconstrict below the area of injury, okay? Which means that blood will sort of collect, it will kind of sit and pool, not able to move very well in that area below the injury, okay? Now, if that is the case, we may be able to vasoconstrict above that area, but we can't vasoconstrict below that area. And so we will now have problems with our vascular system because we're not able to move blood effectively. That smooth muscle is meant to work on its own and work together with the rest of our body to say, okay, we need right now to be constricted, or we need right now to be dilated, depending on fluid volume balance and body needs. Now, in neurogenic shock, of course, we can't vasoconstrict. If there's been any sort of blood loss associated with our injury that's caused the spinal cord injury, now we've lost fluid and in our circulating volume, and not only that, we cannot vasodilate effectively with our autonomic nervous system. Wow, that sucks. They have here that neurogenic shock is most likely to occur right after the event. But the interventions with neurogenic shock are the same as any other type of shock, really. You're looking at making sure that person has fluids, colloids, and then pressors, maybe even like atropine if you need the heart to pump faster. But at the end of the day, it's a type of shock. Spinal shock is not shock. It's a wannabe. It's a poser. But neurogenic shock is the real thing, and you have to treat it like any other type of shock. But it's nice to know physiologically why it presents as a type of shock when it's a spinal cord injury. We're looking at complication prevention. So that has to do with any sort of hospital-acquired issue, hospital-acquired problem, as well as problems relating to that spinal cord injury. Of course, a complication of having it be worse, right? Turning a complete or an incomplete breakage to a complete breakage, perhaps by mishandling at the scene, not immobilizing that neck. Any sort of pressure injury, because there's a chance that this person will not be able to move effectively for a while. Any sort of pressure injury is a complication we would love to prevent. Atelectasis, that is definitely something we would like to prevent, because there's a chance that anything. They talked about it here. Our diaphragm is like right here, kind of at like T7, kind of. If our diaphragm is not working effectively, we're not able to get that cough, deep breathe action as well as we might like, meaning that we need to be really making sure these people are breathing well. Respiratory needs to be in to give them breathing treatments, just so that we can prevent atelectasis, because we don't want that to turn to pneumonia, and now they're in an even bigger problem. Yeah. And then, of course, psychological support. This is a very jarring thing. This is something that can change somebody's life forever, and it can happen in a second, which is crazy. But it's really important to be able to have kind of a heart for these people and be able to listen to them, be able to sort of help them through the process, giving them the support that they need and the resources that they need to be successful through the process of rehabilitation and coping. And that's the next phase, is of course the rehabilitative stage, where you're giving them psychological support, you're working with that functional ability, recognizing what can they do, what can they use, and what can't they use, what can be regained. And that's where there's a lot of it that has to do with the extent of the injury, what's been lost. Because if you're looking at what's been lost, you can kind of say, well, what do we still have left? And how can we use what we have left to bring back as much of a what you had before as possible. Because these people are worrying about jobs, they're worrying about providing for their family. What is it going to even look like for them to live? A lot of people will look at a spinal cord injury, especially if we're talking about paraplegia, and say, what do I have to live for? And that's a hard question to have to consider, because it completely changes the way a person views their life and their abilities. But by working with the rehabilitative services, PT, OT, rehab services in general, there's a lot of amazing things that have been able to happen, little things that can change the course of the person's ability. By even just being able to move a hand a couple of inches, you can completely change the way somebody is able to get around. That's the difference between being able to control your own wheelchair and maybe not being able to do that. So, and there's constantly new things being created to help these people in getting around and being able to participate in the human experience. But that's something that you can't just say, well, don't worry, it'll all, you'll find something, because in that moment, they don't know. They don't know where their abilities are going to be in, a couple of months. Some people might be hopeful and they might say, oh, I know that I'll be able to get really close and I'm going to work really hard. And some people might just be like, no, I just don't think I can. I've lost everything. That can be really hard. But anyway, that goes a little bit back into the psychological support. However, that functional ability extends more than just hands, arms, legs. That also has to do with the GI system above the injury, and maybe even below the injury. These people are going to be undergoing bladder and bowel training, potentially to be able to have some foresight into when they'll need to go to the restroom, so that they're not incontinent. Yes, they are incontinent, but by being able to know their toileting schedule and when they need to go and etc., knowing how to straight cat themselves if that's possible, those are things that can really give them a sense of self-efficacy over their abilities in their life, which is really important. Really, really important. Okay. We'll kind of talk about that in a bit of the next slide where we'll talk about interventions. But autonomic dysreflexia. So you know how we talked about the vascular system with neurogenic shock, where everything below that injury is going to be automatically vasodilated, okay? Because that's just the normal way that those muscles relax, is into vasodilation. If they can't vasoconstrict, they'll be dilated, okay? So in autonomic dysreflexia, the vascular system above the area of injury says, what do you mean there's a ton of vasodilation down there? That's terrifying. We need to extreme vasoconstrict as let's call it a coping mechanism. It looks at that and goes, close everything. Well, okay. Everything being vasodilated is not good, first of all. That's not a good thing. But in that same way, having everything be vasoconstricted is also not a good thing. Extreme vasoconstriction causes a blood pressure to just go insanely high, and there's not much the body can do with a high blood pressure that becomes that hypertensive crisis. You get to a point where your body really can't get the most out of the constriction, because the blood pressure is so high that blood's really not able to get, oxygen's not actually able to really get into the tissues. The blood's just moving so fast that the body's like, hey, slow down, I can't get anything from you. This comes from a bunch of different areas, a bunch of different places. I'm going to pull up the actual page for this, because there's an article that I need to look at, and I would love to look at here. Boom. So, autonomic dysreflexia happens when there's some sort of negative stimulus that causes the issue of vasoconstriction, okay? This can happen from a lot of different things, and I have the things that can cause it right here. Those triggers, they all start with B, which is awkward, but it's something that we should probably know about, because these are all things that can send that patient into, it is a hypertensive crisis, really, and it can cause a lot of problems. Really quickly. You're putting them at a risk for having, well, first of all, a stroke, an MI, hemorrhage, intracranial hemorrhage. I mean, there's a lot of things that can go wrong with high blood pressure. Now, here's our 6 Bs. Bladder. That bladder issue is usually due to the spasms because of a urinary tract infection. It could also be caused by urinary retention, kidney stones, obstructed urinary drainage catheters, so any sort of kinked catheter where that urine might not be able to flow, causing a pressure to build back up, or even causing a backflow, which is not good. And then, of course, bladder spasms in general, which, I mean, listen, sometimes your girl gets a bladder spasm if everything empties too quickly. Like, hey, it can happen. It doesn't feel good, though, and that negative stimulus sends your body, if you're at a risk for that autonomic dysreflexia, into a freak-out mode, because it's like, we have to compensate for this, because no one else can. Yeah. Bowel can be caused by constipation or a fecal impaction. Which is not great, but once again, it's because your body is like, we've got to get more resources on this. We need to increase the blood pressure, and it causes this incredibly high, really, really high blood pressure to shoot up. We'll talk about it will present as having like all the signs and symptoms of having that higher blood pressure, and it's going to be really high. Big first one is a headache, anxiety, flushing, maybe even a higher temperature. All of those because your body is going crazy. That blood is going incredibly fast. You're vasoconstricting up the wazoo, all of that. Back passage, what the freak does that even mean? Rectal issues, okay. Hemorrhoids, anal abscesses, fissures, all things. I mean, hemorrhoids in themselves are I mean, that's damage to the area, so yeah. Boils, which have to do with the skin, like damage to the skin, infected ulcers, pressure injuries. You could get a fracture could cause this, dislocations could cause this, pregnancy, sexual intercourse, breastfeeding, any sort of stimulus that kind of would make your body have to freak out a little bit. It's causing your body to try and have to compensate for something. Compensating with blood flow specifically, with any sort of, maybe even an immune response where there would normally be inflammation in the area, and maybe there is inflammation that causes an increase of blood pressure. Pain in general as well can also cause an increase of blood pressure, because your body is like, our blood is how we send our healing factors through, essentially, right? If we need something to be fixed, we send blood there. That's why you can get redness at sites of damage, right? And in all these situations, your body realizes there's something wrong, and they're like, well, send the blood there. And it causes this extreme vasoconstriction, which can cause more problems than anything. Yep. So, of course, when you see this, this patient needs to be sat up first, right, so that we can help to drain that blood, so we're not getting insane, if that can help to decrease the pressure. We don't want blood flowing back up to their head, of course, and then we need to fix what is causing the negative stimulus. For somebody that is also going through autonomic dysreflexia, there's meds that we can give. And especially if this person is at a risk for and has a history of that, a provider may prescribe those meds that they have there, which are, they are vasodilators, because this is a vasoconstriction problem. We want to increase the expansion of the blood vessels so that we can get back to regular circulation, not causing, of course, our chest pain and all that stuff that normally having that extreme vasoconstriction would cause. These vasodilators are going to be our nitroglycerin. They'll usually do paste because it's a short-term problem. And you want to apply that above the level of injury because, of course, below the level of injury, they're not vasoconstricted because they can't. They cannot vasoconstrict below the level of injury. So it's only going to be above the level of injury that they have these signs of autonomic dysreflexia. And then you can also, they can also be given nifedipine, which is a bite and swallow thing for a fast response. Now, you do not give these meds to prevent autonomic dysreflexia. You only give them when autonomic dysreflexia has occurred and you need to stop it quickly, because this can cause problems real quick. So, backboard, no movement, feeling below the sternum. This is just a priority question, and here are the answers, right? Assessing for shock, which we're looking for hypotension, peripheral edema, dizziness, maybe even a higher heart rate. This person needs to be kept warm. And the question is, why do they need to be kept warm? Okay, remember how we talked about, like, the fact that some of the autonomic nervous system is in the skin? Here's the deal, right? They can't regulate their body temperature because they can't, if there's do you tell your body to sweat? Do you tell your body to sweat? No, you don't. Any type of autonomic problem below the area of injury is a nervous thing. And if you have a spine injury, anything below that, your ability to sweat, to not only cool down, but also to shiver, right, is going to be hindered. So, your blood vessels, remember, look at that, they can't constrict. They can't constrict well enough to sense or respond to changes in temperature, giving this person a risk for hypothermia, which is not good. We don't want them to be cold. Cold slows down the body's systems. Yeah, so not good. Not good. They can't regulate their body temperature very well. And that means that they could also experience hyperthermia. Like if this is in the summer and they've gotten this spinal cord injury, they can't sweat to cool themselves down. So they're at a risk for both hyperthermia and hypothermia. But yeah, assess the airway. The higher the priority, the airway is a higher priority, the higher the injury is. We're worrying, of course, about the diaphragm, but of course, above that, we're also worried because all the structures below are the level of injury are going to be hindered in some way. Now, if that injury happened at C3, that does include the airway, and that's a big deal. Assess for cardiovascular dysfunction, specifically a systolic blood pressure below 90. That's a very low blood pressure. That's, of course, our hypotension, which is not good. We don't want hypotension. Assessing gastrointestinal and genitourinary systems for bleeding or paralytic ileus. Bleeding is a big one, of course, because we don't want somebody to just be bleeding. They're not going to maybe feel the pain that bleeding would normally cause if you've got some sort of internal injury, so we want to be looking out for that, because now if somebody is bleeding, that's putting them at risk for developing shock. If they're losing a ton of fluid volume, their body can't compensate for it. It's going to be bad. Dysphagia, difficulty speaking. You can see that one's on the bottom because it could be difficult if they can't speak. Not only because it's harder for us to get information from them, but it's also harder for us to assess their personal needs. We have to be even more on with our assessment skills if they have difficulty speaking. But that's where speech also has to become involved and look at their ability to swallow, at their ability to do anything. So with their airway and esophagus, which are right next to each other, no pressure or anything. Diagnostic procedures, these people get an x-ray, a CT scan, an MRI, take some baseline lab tests. They're only going to get ABGs if we're really worrying about respiratory acidosis from respiratory failure, because ABGs are pretty invasive, like they are getting stabbed for those things. CBC to check hemorrhage or hemoglobin and hematocrit levels. Cervical spine injuries, they can show lymphocytopenia, okay, and thrombocytopenia due to lack of autonomic nervous system function. So lymphocytes, I believe, are a type of white blood cell. Yep, they are. They're produced in the bone marrow and circulate in the lymph nodes. Thrombocytopenia, the thrombocytes, the thrombus, those are our platelets. So if we don't have our white blood cells, we have a low white blood cells and low platelets, we're worrying about bleeding. We're worrying about infection. Those are two big ones. We can just name right there. We're worrying about infection and bleeding. Especially if this is a cervical spine injury, maybe it's even open. We're worrying about listen, if there's an open place that leads directly to your spine, I'm worrying about meningitis in the same way that having any sort of CNS leak would lead to worrying about that. So, spinal cord injury treatment. Here we have a brief look at spinal fusion, the Halo device. Now, this Halo device, it sticks right, it's supposed to help relieve the pressure on two vertebrae that are like really stuck together to help to relieve pressure on the spinal nerves to allow that area time to heal, okay? This person will be wearing this for 6 to 12 weeks. They literally screw the head part of this into this person's skull. It's pretty metal. Pretty metal. But it is, it's not fashionable, but it can really help to increase the chances that this person will be able to heal their spine. They have here this talk about sympathetic nervous system, parasympathetic nervous system. In general, our risks for this procedure and any sort of spinal cord injury, we're worrying about, of course, the respiratory system. Pericirculation is a big one just because there's going to be like vasodilation below the site of injury. Risk for secondary spinal cord injury because of poor positioning and movement and stuff, and of course, all of that. They have here autonomic dysreflexia, which we talked about. Signs and symptoms of that autonomic dysreflexia is just really high blood pressure, really low heart rate, sweating, goosebumps, flushing, blurred vision. They have nasal congestion here, really, really bad headache, and anxiety. Classic symptoms of having a high blood pressure. And then DVT's complication moment. They have here muscle relaxers and NSAIDs, plasma volume expander. That's maybe a bit of a big one so that you can have more capillary blood to help the spinal cord, to help prevent hypertension. Because, if you've got a bigger blood volume, hypertension, your body still has enough blood, and it's got enough blood that any sort of if you've got a big blood volume, your body is going to be vasodilated because it needs more space for that blood to be. Can help to prevent hypertension. Some blah, 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 blah. Diet, increased oral fluid intake, high fiber, calcium, vitamin D supplements, which are our bone friends. We need vitamin D to help us absorb calcium. And then for neurogenic shock, of course, crystalloids and blood products. Yep. They have spinal fusion, where they, these are all used to relieve pressure, to remove damage, to help fix the issue that's been caused by the injury of the spinal cord, okay? So they have all here these different types of spinal fusion, okay? But the important thing is to keep whatever they did with that spinal fusion or whatever, that procedure in place so that it can actually heal. They have the Halo device. Yeah. So, right after the Halo device has been put in, this is important, the person can't really make sudden movements because those screws that are in your skull need to get set properly. We don't need wiggly screws in that person's skull. This person will also not be able to take the Halo device off. So it's really important that we do our best to keep the skin healthy under there, do the best that we can to prevent any sort of irritation injuries. Pain management, so good amount of meds to help to reduce that pain, and then proper diet. La 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 la. Anyway, so that's the Halo device. It does wonders. Like I said, it is definitely not the most fashionable thing ever, but it can really help to reposition that spine, get it in good alignment, and help that person to be able to recover faster than if they did not have that there, at least to minimize the chances that whatever they fixed is going to go wrong again. It causes that traction where they're just holding that one thing in place, because you couldn't hold your head up like that all the time if you didn't have this brace. So it can help a lot. That goes into your head, by the way, those pins. Anyway, so yeah, these are the differences between spinal shock and neurogenic shock. In that spinal shock happens immediately. It's, remember, that flaccidity that can last, well, they have here 48 hours to several weeks, but it is temporary, where you just get flaccid. Neurogenic shock can occur within 24 hours of the injury, and it says it usually does, so after 24 hours you're less likely to get that, but I'm not going to say you're not likely because that's not true either. More likely with injuries above T6. And why is that? Well, let's go back to, I think there's a picture here on this one. T6, look at that. Boom. That's our airway. That's literally our airway. If we've got an issue with our airway here, anywhere above T6, that's our heart and lungs at least that are are okay. Everything below that, though, our liver, GI system, stomach, spleen, kidneys, all of those are at a risk for for becoming not oxygenated. And those are, at least our kidney, those are vital. We need those. We need those. And if there is a lot of inflammation above that T6 area, which we could call our diaphragm, we are looking at a decreased ability to get in air, putting us at risk for developing respiratory alkalosis, respiratory acidosis, I guess, where we're not able to breathe very well, which can cause our body to kind of freak out. Severe hypotension, bradycardia, warm, dry skin. Why is our skin warm? Blood pools in the veins because it's vasodilated. Oh, it's all making sense now. Okay. So, yeah, it's going to be warm because there's a bunch of blood just sitting there like, so when are we going to get back to the heart? And the blood vessels are like, I don't know, man, but I'm taking a break forever. That's so embarrassing. No, and it's of course going to be dry because you can't sweat. You can't sweat below that because that's autonomic. Hey, when somebody figures out I say you sweat and then you start sweating, I don't know. I don't know. Medications, steroids to reduce inflammation. Any sort of inflammation in here is going to cause more problems up and down. We don't want those. So especially if they're getting in there and they're doing some sort of invasive procedure, like some sort of, I don't know, spinal fusion process or whatever, steroids will likely be used to help reduce inflammation. Which intrathecal, they actually put intrathecal means they're putting it directly into the spine, which is what is baclofen. It's a muscle relaxer to help relieve spasms. Probably help with some pain in the spine. So they pump that right into the spine, pump the baclofen right into the spine to help relieve spasms. Methylprednisone, I believe, is a steroid, but I'm gonna double freaking check. Yes, it is. So that'll help to decrease the inflammation. Isotonic IV solution for any sign of neurogenic shock. Atropine sulfate, of course, neurogenic shock. Vasopressors, of course, neurogenic shock. That's why they're in red. We talked about autonomic dysreflexia, which, remember, the common causes for that are going to be any sort of bladder problem, bowel problem, skin issue, impaction. Maybe if they're pregnant as well, or I don't know if they're getting freaky. Listen, and anything that would cause the body to be like, hey, we got to do something about this. Why aren't we doing anything about this? And then it's going to cause that increased blood pressure. Yep. So for somebody who has had a spinal cord injury, these are all aspects, immobility, nutrition, elimination, sexual function, and psychological aspects that this person is now going to have to sort of reconsider. Like, what does it now look like for me that I've had this injury to poop and pee, to move, to eat, to have intimate relationships? Like, those have all changed for this person in a course of maybe, hours. And that can be really hard. That can be incredibly difficult. And the biggest thing for these people is being there and being there to listen, being there to support, and doing the best that you can. Because nobody wants to be in the hospital. That is one thing I have learned. Nobody wants to be in the hospital. If hospitals were not required, okay, because nothing ever bad happened, the world would be much happier. But unfortunately, we have to have them because things don't work that way. And when it comes to having somebody in the hospital, they don't want to be there, okay? And I would rather them be well than to not also have to be there. So it's our job as nurses and in general people who work at the hospital to do our best to make our patients feel safe and feel as much love as possible while in that space. So, big one there. And that's just a little video clip, but yeah, There we go. I'm gonna briefly we've done this in record time, which is crazy. I'm gonna briefly go over some of the stuff here, these different factors which we talked about in class. Um, so measures for spinal shock, watching their breathing, monitoring vitals, watching their skincare. Another aspect of this that's oft forgot but is pretty consistent when you go to the hospital is VTE prophylaxis. We, of course, do not want them to be building some fancy DVTs that could become PEs or MIs or any sort of ischemic my stroke. That's what it is. So VTE preventions are important. Bladder and bowel training, and of course psychosocial support, blah blah blah. I think we've talked all about these things actually. Raised bed, raising the head of the bed for a autonomic dysreflexia, just to help to get that blood to not be like pooling up in the head, and that can help to decrease the blood pressure. Nitroglycerin, oral nifedipine. Nitroglycerin, remember, that's the paste. Monitoring vitals. You want to check and see that blood pressure is actually going down, and check that their heart rate is gonna eventually go back up. Bowel and bladder training. Pin site care. We don't want this person to be getting an infection because this person does have a halo vest, so we want to make sure that this person we don't want them to get meningitis. No meningitis. So checking those pins, making sure they're cool, and of course that skin integrity as well. You can't do too much because you can't take the vest off. You can't really do much with it, but you want to do your best. You do your best to keep them clean, keep that area underneath from getting red and inflamed and angry, because that skin problem could potentially be at risk for making them go into an autonomic dysreflexia, which is not fun for anyone. Which makes this VTE prevention even more important, because imagine they did develop a DVT and then they go into autonomic dysreflexia. Hey, maybe that could cause some problems. Who knows? Check blood pressure every 2 to 5 minutes while treating, because they are not. They have here this guy right. I remember there was a question in class, and it was like the blood pressure was like 190 over 120. I was like, that's the craziest blood pressure. That's crazy. And I'm sure that's not even the craziest one that exists, okay? Autonomic dysreflexias, they do not play. So checking that blood pressure every 2 to 5 minutes, you're in that room the whole time, like making sure that they come down from this, because that could be life-threatening. Checking for bowel or bladder issue. Yeah, what's the problem? What's causing this? And maybe we can, get there to help the symptoms go down. Okay. Hey, I feel good about that, actually. I think we're good to go, and we'll do our best.